welcome everybody to our live Q&A today. We hope that you are enjoying the conference so far. And I am pleased to be your moderator for this session. My name is Leah Foster Smith, and I'm a nephrology nurse practitioner. So I want to start with welcoming each of you to the Q&A. We are excited to hear some of your questions and get them answered by our experts. So I'm going to introduce both of our panelists. We have Dr. Jenny Flythe, who has spoken to us. If you hopefully have listened to her presentation on individualized volume management in hemodialysis. Dr. Flythe is a nephrologist and a clinical investigator for the University of North Carolina School of Medicine and a director of dialysis services at UNC Hospitals in Chapel Hill, North Carolina. We also have Dr. Siqin Ye. He just finished speaking to us on telemedicine in the time of COVID-19 that we are still in, right, and ongoing. Dr. Ye is the Associate Chief Medical Officer for Columbia Doctors. He is also faculty in the faculty practice of Columbia University Urban Medical Center and oversees telemedicine for Columbia Doctors. So we want to welcome them to our panel. We want to begin by opening up the floor to see if you have any questions for our speakers on either of their presentations. Don't be shy. All right, well, while you're thinking of questions, I will start with a few of my own. And sometimes our own questions are other people's questions as well. So I'll start with Dr. Flythe. I do feel like volume management is something that impacts all of us, whether we are on the provider team, whether we're on the nursing team in the dialysis units. I enjoyed your case studies. I know I am constantly trying to figure out ways to individualize these options for patients. I know sometimes we are pushed into either just increase their time or please stick to this UF rate. So I think my first question for you is, in some of those individualized therapies, have you been approached or about coming in and truly making sure at least everybody's under 13, or have you been allowing that UF rate at times to go to 15, 17 on your patients?
Sure. So great question. It very much encapsulates what I think everyone is feeling pressure to do, which is to lower the UF rates below 13, because that's what our surveyors are looking for. They have a line item for it on their tool. And as everyone on this call knows, it is in the quality incentive program now, looking at the proportion of patients who have ultrafiltration rates measured in a 1-week period that are over 13 mils per hour per kg. So my stance on this is I am not in favor of using UF rate of 13 as a absolute stop in terms of the fluid that we take off. The challenge that we run into in this area is that the data is, we don't have comparative data. So the question is, do we leave our patients little volume expanded, or do we expose them to a higher ultrafiltration rate? My bias on this is I think that long-term volume expansion is worse. And so it's better to occasionally use higher ultrafiltration rates to get a patient dry. However, exposing a patient long-term to higher ultrafiltration rates on the order of 14, 15, 16 every single treatment, we do believe that that has some potential long-term, consequences for patients. However, an occasional treatment with a UF rate above 13 on a Monday or Tuesday may be necessary in order to get them at least on the path to being dry toward the end of the week. So I don't use a hard stop of 13. And in fact, if I find that anyone's using it, I ask them not to use it. However, I do think patients that are routinely having the UF rates above 13, that can be a good sign that something's going on with that patient. We need to reevaluate and we need to consider some of those individualized strategies. But again, I don't use it as a hard and fast rule.
So I did like your in your case study how you had individualized, especially post-weekend, whichever their weekend is. But I can already see, like in my units, am I going to be able to adjust times because, seat times are back to back and we're trying to do that rollover. But I do love that option. I know sometimes on my end, when I'm rounding, I may create that longer time where I'll sequential the first hour just to see if I can get 1.5 liters, 2 liters off, and then finish that. And sometimes that becomes a consistent order for my patients. But I definitely think that'll be a tool I take back. And I'm sure some of the nurses will hear that as well. And thinking about that, if we can accommodate that kind of time change. Now, I will tell you, I have a few nephrologists who are real sticklers about 4 hours and never let patients run under that. So, you know, in that case study, you were able to give them over the week time, it was a balance of time. So I will have to see how that goes over. But
yeah, no, and I think there are 3 things in that I guess I would respond to. So, you know, nowadays, if you look at the ultrafiltration rates in the United States, and I showed this in the presentation, we've seen a downward trend in national averages. And so when you look at it at a clinic level, it's really rather unusual for a clinic to have more than 10 to 15% of their patients with a consistent UF rate above 13. I mean, we're all going to have the outliers that have their football Sunday and they come in with a really high interdialytic weight gain, but in general we've declined. And so when you look at it on a clinic level, it's often fewer than 10% of the patients who might need some kind of adjustment, and oftentimes many of the other strategies that we would use that would not involve treatment time extension or any kind of sort of titrated treatment time may be better for them. And so, you know, in this clinic from that patient that I showed you, that's a 120 patient clinic, runs 2 shifts a day. So this is it's a busy clinic. It's a 36 chair clinic. And there were really only a couple of patients that we needed to consider that in. And so I think that when you actually get down to the clinic level and the patient level, really only a couple. We did have to move the positioning of a couple of patients because of start and end times. But again, that's what's attractive about making it the set schedule. I think when I first kind of got into this, I thought, oh, well, maybe you can titrate the treatments. Well, that does not work in the real world because you need to know what time they're going on, what time they're coming off, not only for the clinic, but for the transportation and everything else that comes along with it. And so I think the idea of being able to do that on a weekly basis is useful for that. As for treatment time, I tend to be a bit of a stickler for 4 hours, and then I start my patients on 4 hours. However, I do find that there's some patients, particularly my smaller patients, who seem to have more post-dialysis fatigue and washout, and they've got a clearance that's well above any metric that we use, and we know that improving clearance beyond a certain threshold doesn't seem to improve outcomes. So in those cases, I often will do, if they're not a big weight gainer and it's not going to drive their ultrafiltration rate up, I will do time-limited trials of dropping their treatment time to 3.5. I used to refuse to go below 4 hours, and that's something that I've really changed on over the years because I do find, particularly when it comes to symptoms, that some patients have less symptoms with a shorter treatment time. And if we can keep their UF rate down and we can keep them at the adequate clearance, at this point, there's not data to suggest that that's causing harm, particularly when we're talking about, 15 or 20 minutes.
Sure.
And then the third piece I just want to address is the issue of sequential. So there really is no data on that. And so just to make sure everyone's on the same page, what she's suggesting is that you do ultrafiltration only for an hour typically, then followed by UF and HD. And the idea is, and I think what many of us observe clinically, is that patients often tolerate UF only better because they're not being subjected to the concurrent flow of electrolytes that's happening when you do a concurrent hemodialysis. And I agree that I do find that there's at least a subset of patients that does better with that. But oftentimes when we're doing sequential, in that hour of UF, we actually try to take off a fair amount of fluid. And so if you look at what their ultrafiltration rate is in that period, that 1 hour period, it's often quite a bit above 13, sometimes on the order of 16 or 17. And we don't know if that's okay, and kind of how how that plays out into the longer term balance of things. So I would just say I don't disagree with it, but I don't think there's evidence to guide us to tell us if that's really safer than having exposure to a higher UF for a longer period of time.
Yeah, we do get the questions, oh, do we calculate the UF for this, hour, and again, old school, we didn't, but it's definitely a great point, but it's definitely out there. And we do have one comment on this, and then I actually have a question for Dr. Kayi that's come in, but it looks like one of the attendees says, I find it difficult to stick to the 13 milliliter rule for those patients who are smaller, which kind of goes with what you were suggesting, especially those that are under 65 kilograms. Considering that as a rule of thumb is no more than a liter of fluid per day, that already brings them to the edge of total losses and gains. And the smaller patients don't always need the extra time for clearance, so it's been harder to get our physicians on board to extend times as well for those patients.
Yeah, no, I would agree with that statement. And, one of the other kind of questions that remains in this area is, are we really thinking about ultrafiltration rates correctly? So the 13 is 13 mils per hour per kg. And so it's the mils per hour, but we're indexing it to body size. And so there have been questions over the years, well, maybe it should just be mils per hour. Well, what if you use BMI? What if you use body surface area? Is there a better way to do this? And so we've done a couple of analyses where we've looked at putting BMI and BSA in the denominator and really did not see a huge change in terms of risk. However, what I will say is at the very extreme ends, and by extreme ends, I mean kind of the upper and lower, like 5% of patients, you do see that association start to change, which may suggest that there may be some differences based on body size. I don't think that this is an entirely answered question yet. But just the point that this person is making, again, the way that the CMS metric is specified, you can have a couple of patients in your clinic who may have higher ultrafiltration rates, and you may need to just allow that. I mean, if they're doing well clinically otherwise, I would not arbitrarily increase a treatment time, particularly if you're not taking off a whole lot of fluid, if it's a lower weight gainer.
Agree. So Dr. Kayi, one of the questions that's come in for you is, obviously, in all things telemedicine, especially in COVID-19, how have you been dealing with the unpredictableness, right, of technology, dropping calls, poor internet connections? I know one of the things we've come upon, I'll add on to this and then we'll let you comment, is I begin with a video, it drops, I convert to phone. Do you bill video? Do you bill phone? Remember how we were, so I'll let you answer some of those.
This is a great question. I think there's sort of two main parts from some of my experience of how to handle these type of situations. It's definitely a very common scenario, both sort of patients, comfort with technology, and also some of the issues like internet connection. I think there are a lot of things within our control. So on the clinician side, making sure that you're in a space with good internet connection, with good high-speed Wi-Fi, that's absolutely important, because you do get into this situation where people are not realizing that sometimes the connection issues on their end. The other part is having good communication with the patient really throughout the pre-visit, the scheduling process, giving them instructions that they should and make sure they're in a location with good internet access, that they have the devices that, for example, support any software that might be needed, such as Zoom. I think having that communication up front and really having that being a standard part of the preparation process for patients, at least for the first few telemedicine visits, I think that's also really, really important as well. So I think that's number one. I think the other part is, especially during the public health emergency, where there is really a lot of flexibility for the platform that can be used, and where there is a lot of available platform now. I think it's really good to plan out redundancy, to have a backup system. So for example, in our experience, is that we have an Epic integrated Zoom platform right now that we use for majority of telehealth visits. But I will tell the clinicians that in a scenario where there's a technical issue, patients are struggling to connect, we don't want our clinician to be IT support. We want them to take care of patients. So when that happens, we want them to use our backup option, which is a Doximity, where they can just directly text a link to patients, and the patients can join. And often that's easier. I think doing these two approaches really does help cut down on the technical issues. I remember in April, May, and then even throughout the fall, I was used to be getting a lot of the feedback about technology connection issues. I think now I pretty much hardly get any of those type of feedback anymore once they pop up. Partly because I think we have sort of made our workflow to enhance patient experience in this fashion and making sure that they consider these common things that can pop up and address them. And also, I think partly there is also a learning curve where on both the clinician and patient's end, whereas they do telemedicine for a while, they learn a little bit better how to troubleshoot as well. So it will keep happening, but I think once we prepare for them, it is a very manageable issue that occur for telemedicine.
I think one of the things that we've come upon is if we've had a couple different scenarios where on the patient end it's just not working, we've now opened back, each clinic's different, we've opened back up our doors for face-to-face visits. So those particular patients, we're talking with them about, technology has been an issue multiple times. We would definitely like to see you back face-to-face. For those that are still really liking the telemedicine and it's working, we're trying to extend those services to them. But I think we're all living and learning, correct, during this to see what works. With nephrology, it's difficult. We need blood work, right? I mean, we're all about the blood, right? So somehow we got to get you in to get your blood work. And then we can really take care of things pretty easily via telemedicine. But, I think that's been one of those hard parts, I think, especially during the initial part of the pandemic, was how do we get these patients in? Do we feel safe bringing them in? How do we get that blood work so that we know? And that's, of course, on our office side patients, not our dialysis patients. I mean, they were coming in anyway.
Absolutely. And I think part of what our challenge really going forward is really figuring out both at a patient level and at a population level, really, what is the best mix of telemedicine? Because I think as I mentioned in my talk, I think there are some, concerns that now we are realizing about things like blood work, measuring blood pressure, some of the care delivery part of telemedicine is that people may, just because the patient's not in front of you, that may slip the mind of the clinic taking care of the patient. So sort of figuring out the right clinical pathways and saying that, this mixture of telemedicine is good for dialysis patients long-term that, or home dialysis patient, for example, some of the visits can be telemedicine, but sometimes they do need to come in and get those labs drawn and then get, things taken care of. I think defining that is going to be hugely important. And then I think we have to follow where patients are at. We get feedback. Some patients, they will say that during the height of COVID pandemic, telemedicine was the only option, so they did it, but they didn't like it. They liked the in-person, they liked the camaraderie of the waiting room of meeting patients in more conditions, including, for example, some of our dialysis patient education groups. So it's not something that we should force patients. I think it's one of the options for patients to have for those who are suitable for it, and we should figure out what are the best way to deliver care using telemedicine.
Well, and I think one of the kind of hurdles that we came up against was, of course, what are we going to do with our dialysis patients? And I think each practice looked at this different. I mean, I worked for 35 nephrologists, and it was like the decision was we're going to go see those patients. So we actually continued to round on all that were non-COVID. Now, we had some COVID units. Still to this day, we have COVID shifts and COVID units, and we are rounding virtually on them. Even in those units, something that we've come up against, and I'm sure some of the nurses in the audience know this, are they understaffed? Can they man the computer? Because they've got to go with the computer to the patient. So I think we have to give and take together. Can they actually accommodate and do the virtual visits for us? Because they have to be there the entire time. So we have to be respectful of that as well.
Right. And I think that's for the inpatient side. I think fortunately, things we're at a different place now than we were March and April. And some of the challenges are different because for some of these inpatient telemedicine use cases, the patients often are not able to navigate the technology by themselves because, they're sick, they are hooked up to machines. So it's a really great challenge. And I don't think we have the perfect answers for it. I think in the future, there'll be, one of our vision is to have, for example, a camera, a sort of a tablet-based camera that's within every hospital bed or within the ICU, so we can easily access it without having someone physically going into the room. Because we actually also don't want a situation where just for the sake of telemedicine visit, we increase exposure for the staff. We're already having a lot of risks as well. So I think that's a big challenge for how we approach it on the inpatient side.
Agree. So it looks like Dr. Flythe, we have a question for you. And the question is, how do we explain or document appropriately the greater than 13 milliliter kilogram an hour for chronic small patients that we have to the state when they come in for the audits?
Yeah, so that we're kind of heading into dangerous waters here around making too many recommendations around this. I mean, the regulation is what it is. So they will count your patients that are above 13 mils per hour per kg. And at least to my knowledge, there is no way really out of that. However, in all things, as practitioners, we want to show that we've been thoughtful and that we're aware of the regulation. So I think in notes, you can simply note that the patient is above 13 mils per hour per kg. You've taken these measures to try to lower it, and based on your risk-benefit assessment that may include symptoms, quality of life, and other things, you've made this choice. Whether or not that is a get-out-of-jail card, I don't think so, because that caveat is not written into the regulations. But again, I mean, ultimately, we're trying to provide the best patient care, and the best patient care may be, in some cases, having a higher ultrafiltration rate. And as long as you've documented that, I would say, as the clinician and as the clinic, you just accept kind of the black mark that you might get for having a couple of patients like that. It is probably a problem and probably reflects not great practice if that's becoming 10, 15, 20% of patients in the clinic. If it's 1 or 2, I would doubt that would be a major issue for a clinic.
Well, and I think with some of the auditors I've dealt with, when they individually question you, if you can, express appropriately, they see your documentation and they understand where you're going, I think on those individual cases, it will be fine. I agree with you. If it's a large section in your clinic, then that's a little bit different and maybe head in the sand and maybe things have gotten a little awry.
Right. And that probably does suggest that you should take a look at your volume management practices. And that's not a bad thing. I mean, I do think that that's what this measure has done, is made us all pay attention to something that was not paid attention to, or at least didn't have parameters that helped target what patients we should be focusing on. So I do think the byproduct of it's good and that we're paying attention to it, but we just can't become owned by it.
Well, true. Or measures when you're walking in and it's like, anybody that's been over a kilo of their dry weight, we need to change their dry weights. Well, there's a spectrum there and there's processes there. And I think that's where sometimes the rules and regs can be hurtful if we're just trying to put everybody inside the same box. Mm-hmm. There was another mention about blood volume monitoring, such as crit lines. I don't know if you have crit lines in your area, in your outpatient units, and how that's factoring into your fluid assessments.
Sure. So we do have crit lines in our outpatient clinics. The way that the question is actually phrased is around the idea of if you can keep someone in a certain blood volume monitor profile, then maybe that would be a sign of acceptable volume management. And I would say that the evidence probably doesn't, we probably don't have good enough quality of evidence yet to really support that. We have some ideas around what might be favorable trends on the blood volume monitor, but I think as all of us that practice know, there's certainly outlier patients and not everyone follows the expected trends. And honestly, the data around blood volume monitors, with the exception of the CLIMB trial, which is really our only randomized trial of these monitors, which showed potential harm with them, all of the data that we have around them is observational. I think it's really difficult to look at a number of things about volume management with observational data because we typically don't have very good data on residual kidney function and a whole variety of factors that may be contributing to the clinical picture. So I guess I would say that I don't consider necessarily the profile that shouldn't make us necessarily feel safe about things. That being said, I do use them in practice. However, I tend to use them more almost in retrospect. So I will look at people who have a flat line and they've run flat for a couple of treatments, and that might be a patient on their next treatment that I choose to challenge their dry weight a little bit. I use them less to guide me on kind of a hour-to-hour UF rate based on tolerance. Now in the hospital, that I do tend to use more real time to help as potential prediction of future hemodynamic instability. But I think in the outpatient setting, when you don't have a clinician in the unit all the time, that using them as a marker and finding people who might be volume expanded who you want to challenge at future sessions is a good use of them.
Agree. And what I've seen, it varies around the country if you even have this to rely on or look at. I think it just adds to my decision making, if you have that access. Am I going in the right direction? And I find sometimes people are running the flat A profile when I think they're dry, so I don't depend on it per se always, but I think it's there as a good tool marker here.
I agree. It's another data point.
Absolutely, absolutely. We have just about 1 minute left. I do want to ask you one last question, maybe if we can get it in, Dr. Kayi, is do you know anything about waivers? Do you think they'll go past the end of this year?
Yeah, I think that's a question everyone's wondering about. If you look at what's happening, I think Medicare CMS is saying that public health emergency is pretty much planned to last till at least end of the year, and then they'll give advance notice. Remember, I want to say it was probably like 30 or 90-day period before they end the public health emergency. So at least we have that clarity. Unfortunately, some of the issues about sort of the coverage policy for Medicare, where the site of origination can be patient home, that's something that still requires a legislative fix. And CMS has been very clear that that's not a determination they can make for themselves. So hopefully this is something that I think a lot of advocacy is currently being done. This is something absolutely we need the Congress to take up. On the state side, I think this is something that's unfortunately very confusing because different states will have different licensure requirements, and the common scenario is that, let's say I'm using New York as an example. For New York, a lot of our patients are coming from New Jersey, Pennsylvania, Connecticut. So part of this is understanding not just your state's policy for patients coming from right beyond the state in the adjacent states, but understanding what those states' policies are, and sometimes there are things like temporary licensure mechanisms that you have to follow up on. So the way we think about this is we think that right now, for our adjacent states, we want our clinicians to be ready to take care of the patients for continued care. We want to, make sure they follow the state level regulations, which includes getting some temporary licenses when it's required. And for now, that's fortunately most of what's required right now. But long term, also thinking about if there's models where they want to continue to provide telemedicine service across the state lines for their patients who might live in the adjacent state, then sometimes that will involve getting more permanent licenses. So we're encouraging our clinicians to take a look at their own practice panel and make those decisions. So unfortunately, it is fragmented, and hopefully, we'll continue to push for sort of higher level legislative and regulatory changes to make these processes a little bit easier.
Well, I want to thank both of you, Dr. Kayi and Dr. Flythe, for your time, your expertise. I think this has been an excellent discussion. Thank you all for your questions as well. We hope you enjoyed the rest of this conference, and we're going to hear some final words today from our Executive Director for the Renal Research Institute, Terry Sullivan. Have a great conference.
Thank you, everyone.
As we wrap up day one of the Nurse Care Team Track, my wish is that you benefit from the creative and valuable online networking opportunities,
such as the poster sessions, industry symposiums, and social media lounge and chat rooms that build and foster relationships and create collaborations that would not otherwise be accessible offline.
The networking sessions provide the opportunity to develop online interactions that foster relationships and collaborations with industry thought leaders, medical professionals, researchers, and scholars. They also provide a place to discuss exchanges and developments on the latest practices in kidney care and treatment. As a reminder, if you haven't had an opportunity, please view the speaker's prerequisite sessions in the on-demand library. This will enable you to maximize your experiences and participation in the live Q&A sessions tomorrow.
As an added benefit, the poster sessions, industry symposiums, social media lounge, including the chat feature, will remain available until August 1st, 2021. Thank you again, and we look forward to seeing you tomorrow.